Okay, these are some of the modifications for developmental disorders. I've mentioned some of the various treatments that are helpful in terms of psychotherapy. And I wanted to, because we're limited in time, I'll focus on the medication aspects. One thing is that we do have quite a bit of the population with autism spectrum disorder does have anxiety disorders. It's a common comorbidity. These are some of the different comorbidities that this population has. So what we want to think about in terms of targeting the symptoms with medication is what are the symptoms that we're targeting. And so that really, thinking of symptom clusters and medication choice in this population is important. It's not so much any one specific disorder, but looking at the symptom clusters. So I've talked a little bit here about what are we targeting in terms of the serotonin drugs. One of the things we want to think about is if they have anxiety, irritability, and if they have OC behaviors. One of the challenges we have is in this population you may have ritualized behaviors that are more part of the autism spectrum or the Asperger's. Some of those things may or may not respond to SSRIs, but oftentimes they have comorbid obsessive compulsive behaviors that will. The other area that I've mentioned down here that I commonly find is helpful is they have a lot of, again, rigid thinking, and the rigid thinking in and of itself can lead to aggression, can lead to them getting upset and frustrated when they're asked to do something that they're not comfortable with or they don't like. And I find that the SSRIs can just reduce that edge they may have in terms of the rigid thinking and allow them to just function much better. So I think along with what we would say obsessive compulsive behavior specifically, I think that rigidity of thought and perseveration can be very helpfully targeted. Certainly if they have specific anxiety disorders or depression comorbid, again, not uncommon in this population, particularly with the high-functioning autism, we want to think about the SSRIs. Then the other areas are the stimulants. In terms of if we're focusing on attention concentration problems, we really should try those. We have to start at low doses and we have to monitor closely. Some of these patients will get more irritable on the stimulants. They may become aggressive on the stimulants. Again, we have to be cautious, but again, we can have good results. The guanfacine and clonidine I found particularly helpful with impulsivity, explosiveness, and restlessness. Again, there are studies on this as well. One of the things to think about is if they don't tolerate the stimulants, that's often the second line that I will go to because that can be very helpful in really managing some of the ADHD as well as we can. They will tolerate some of these patients Strattera, but some will not. So again, it's worth considering, but I find that the guanfacine and clonidine are more effective. We do often have to go to the atypical antipsychotics if we try some of these other things and we find that their aggression is severe or that they have certainly comorbid mood disorders. It's certainly appropriate to try the atypicals. I do see a lot of patients with these comorbidities. We actually have a Center for Autism Research. Ed Cook is with us at UIC, and Dr. Leventhal was there for many years. So I do treat a lot of the patients on the spectrum. I'm always trying hard to try some of these other medications first before I move to the antipsychotics, because the problem with this population is, okay, they're going to have this disorder all their life. We're not going to be able to cure it. So we want to try to reduce the exposure to antipsychotics over their lifetime. So putting other interventions in place, certainly psychosocial and behavioral, along with medications is very important, and trying hard to see what medication combinations could help them prior to putting them on a long-term antipsychotic. The other thing is to use antipsychotics for a period of time, helping them engage in other types of interventions, and then reducing them over time, maybe needing it again. But again, reducing the exposure over the long term. Okay, these are some other of the psychosocial things. Just wanted you to know about some of the research that's done with CBT in this population has found to be very helpful. So I've given you some information. I don't have time to go into that today. The other thing I wanted to mention is neurofeedback and also some of these innovative tools. This is called a stress eraser, and it allows the child to actually monitor how they're doing in terms of their heart rate and heart rate variability and their what's related to anxiety. And a lot of these kids, they respond better to something that's concrete and visual whereas it's hard for them to appreciate and understand the other aspects of the symptoms. So I find using some of these tools in the medication process and in the psychotherapy process is very helpful, so they can see the effects it's having on them, and they're more likely then to participate and feel that it's helping. Because as you know, with this population, it's very hard for them to tell us what are their symptoms and what's changing or not changing. So tools like this can be helpful. In terms of substance abuse, this is just giving you a sense of some of the symptoms that we see in adolescence. I've just summarized some things. I have a psychologist that works closely with me on my team that has a lot of expertise in substance abuse. So I mentioned the craft earlier. We really want to think of comorbid disorders, anxiety being way up there and depression, and then certainly ADHD as well. So we want to be thinking about treating the substance abuse problem, but concomitantly treating these other disorders. Part of the mistake we make is saying, well, unless you're sober, again, in the community it's not that uncommon. Unless you're sober, unless you're substance free, we're not going to be able to treat these other conditions. No, we need to be treating the comorbid conditions as well. Motivational interviewing is something that can be very helpful and important. I've given you several slides on that. It's very important to engage the child and adolescent in their treatment process. We need to understand what is it that the substance abuse does for them. What is it doing? Is it allowing them to deal with things going on in their life? Is it allowing them to somehow feel like with anxiety disorders relaxed for the first time, get away from these thoughts that are distressing to them? We need to understand that, and then we need to work with them on, okay, what are other alternatives to the substance abuse? The parent part of the team is very important. They're going to need to monitor their substance abuse over time with urine drops and other things at home. Okay, so I've mentioned to you already, social anxiety does seem to predispose also to a higher rate of substance abuse and anxiety and depression. So the motivational interviewing I mentioned has a lot to do with an empathic stance and developing a discrepancy between their goals and their current behavior. The cognitive behavioral strategies also identifying triggers and managing cravings. That's a critical part of the work with substance abuse, is identifying those triggers and knowing what to do when they do come up. So this is just giving you a sense of how motivational interviewing works. This is something we work with the patients quite a bit on. So we need the urine drops and screenings. And then in terms of medications, these are some of the things I want to think about is caution with benzodiazepines. This is relevant with anxiety disorders. We really want to be thinking about what could be some of the risks in this population. I have a lot of my patients who, the first time they take a benzo, they love it and they want to keep taking it. And so we really have to think a lot. We have to think hard about when we first prescribe benzos to this population. I'm not telling you I don't have patients with substance abuse, anxiety, and depression on benzodiazepines, but I'm monitoring very carefully, not only for their use. Are they giving it to their friends? Again, very common practice. Other family members, are they using their benzos? Okay, we've got to be really monitoring very closely. We've got to be cautious with standard stimulants, again, related to the substance abuse issues. This is a big issue at school and college and everywhere else as well. Bupropion can increase the risk of seizures. Just want you to be thinking about that when you're working with this population and we think about withdrawal seizures or we think about seizures for other reasons. Monitoring administration of the medicines, again, is important, and checking for substance abuse in relatives and friends. Okay, I guess now we've got a summary of anxiety, and did you have that on yours, or should I go ahead with this? This is our summary for the anxiety and comorbid disorders, level 3 and 4. I think actually Jeff you've probably reviewed some of this already, but we talked about introducing one medicine at a time, consider benefits and side effects of each. He actually reviewed this already for depression. Fluoxetine can be considered first line. We've also got the other SSRIs and venlafaxine second line. Consider beginning SSRI at a lower dose in patients with a primary mood disorder. Monitor for suicidality. Tolerability of SSRIs, again, is lower in the bipolar population. We've got to ask for a history. With ADHD, I think he reviewed these already. I would say one of the things clinically that I would emphasize with this is myself is I commonly use stimulants and SSRIs. There are several good studies showing efficacy for SSRIs and stimulant use. That is what I reach for first when I have the comorbid patient. As he mentioned, you may treat the ADHD and you may have improvement in the anxiety symptoms, okay? And vice versa. It's not uncommon that we treat one disorder and then we either uncover another or we might actually see one improve. Okay, so I would say, again, reaching for the SSRIs and stimulants, I think it's, it's reasonable and we see good results. And then the atomoxetine is another option. Guanfacine, again, certainly in patients who can't tolerate those meds. Again, emphasizing here, we cannot start these patients on SSRIs first line. We really need to stabilize their bipolar. I think that's the most important thing. But second is we always have to ask for a family history of bipolar disorder. We have to be very cautious about introducing SSRIs into patients who even have a family history. I just have to follow them very cautiously. Using benzodiazepines with caution in that population. With substance abuse, the main thing is the benzos and thinking about using those in this population. But one of the other things, as I highlighted, was we've got to treat comorbid disorders in the substance abuse population. Okay? They have high rates of anxiety and depression. We can't just be waiting for them, their substance abuse disorder to go away first. And then this is the same thing I already reviewed with you just a moment ago in terms of medications with this population. I know we're going to have a whole lecture or a whole section where we're talking about developmental disorders tomorrow. I think this is much more complicated. I know I'm simplifying this very much, so I don't mean to offend anybody. But I just wanted to talk about how you can think about addressing symptom clusters. This slide actually I put together with my colleague Suma Jacob on my team. She's an MD, PhD, and she specializes in the treatment of PDD and the autism spectrum and has worked closely with us on anxiety and that comorbidity. And we've actually done groups. That's what I gave you some references for those things. There are groups that have been developed for that population as well with anxiety and comorbid pervasive developmental disorders.